from a management standpoint, there are again multiple disciplines that may have a role to play: surgical oncology, medical oncology, radiation oncology. And because of all these multiple different disciplines involved, this is a disease where, more so than many others for that matter, but clearly so for other epithelial tumors too, that multidisciplinary discussions and formulation of a treatment plan a priori becomes very critical. This is a lesson that we learned from osteosarcoma, a bone tumor back decades ago, where in the older days we played football, where whoever got the patient first did their thing and then passed on the patient to the next discipline. We've learned the lesson that the diagnostic arm of the multidisciplinary team, meaning the radiologists who interpret the x-rays and scans, the ones who do the biopsy, the pathologists who help interpret the tissue to come up with a histopathologic diagnosis, have to be in the same room and talking to the therapeutic team that then chimes in terms of how best to formulate the care. Because where we get, once we have all the information available, is the simple question that's being posed is, so what's the prognosis for this patient? And it gets back to what are the prognostic factors for the sarcoma. Grade of the tumor, size of the tumor, location in relation to fascia, presence or absence of metastases, right? So the Ajcc staging system is basically designed based on these 4 criteria. And what it tells us in simplistic terms is that tumors that are small, tumors that are superficial, tumors that are low grade or not looking very angry under the microscope clearly are more likely to have a local biology, and that's where the surgeons, radiotherapists are going to take the lead in terms of the management, because as long as you can completely extirpate the tumor from the local area, that patient has a decent chance of doing well long term. You then run into the stage 3 patients, which are high risk primaries, where the size is large, grade is high, and these are deep-seated tumors, where 50+% of these patients will develop metastatic disease in 3 to 5 years. And therefore, the debate is, should there be multidisciplinary care, multimodality care incorporated early on in the management of these patients? For the advanced disease patients, clearly the systemic therapy component will take the lead. But again, this is a disease where we have always incorporated surgical removal of solitary or limited sites of disease pre or post exposure to systemic therapy to render them free of disease. So the take-home message here is that there is integration of different disciplines at various stages of management of the patient, and it can only be efficiently, effectively, and most appropriately adjudicated if the components are talking to each other. So this is where I think local referrals, regional care centers where there is multidisciplinary care and expertise available, they can be very helpful in at least designing the plan, and then which component of it gets done at the center versus farmed out to the community can be worked out on an individual basis. At academic centers, we're all well aware of the fact that there are limitations in the community in terms of the expertise available. So with the best of intentions, if we change the diagnosis, we change the treatment recommendations, we would tell the patient and explain it to them, the why, what, and how. Patient then will participate in the decision-making process, and based on insurance and their own personal scenarios, to where they would get treated. There are instances wherein they will stay at the academic center for their complete treatment if feasible and possible. There are instances wherein it's clearly impractical, in which case we would absolutely partner, if you will, with the local team in terms of implementing whatever component of the treatment that can be farmed back out to the community. And the classic scenario is that in a patient with advanced sarcoma, if it's a standard chemotherapy recommendation that they're not eligible for any upfront clinical trials or something more specific directed at their particular diagnosis, then we would make the recommendation. Not infrequently, we create sample orders and let them carry it back to the local oncologist. We will communicate with the local oncologist and ascertain and make sure that there is comfort level on both sides. And if so, then there can be the shared care over a period of time. They take 2 cycles of chemotherapy there, maybe they come back for the scans at the academic center, so we can help with response assessment and whether to continue treatment or not, and so on and so forth. There are times when even that's not practical, in which case we would have the local team keep us posted on every decision-making time point as to whether or not should we continue, or is there time to switch gears and change. More often than not, if there is surgery involved and complex surgical resections, then they will end up coming back to the local academic center, regional academic center, for their surgical decision-making process.